Most men over 60 accept weak erections as inevitable. They shouldn't. Tonight I am giving you the #1 evidence-based trick I recommend to every patient in my clinic, and the results consistently surprise them. I am Dr. James Whitaker, board-certified urologist, and today I want to give you the most complete, evidence-based explanation available of the #1 trick that I personally recommend to every senior patient who comes to my clinic with weak erections. I have seen this approach transform outcomes for men who had accepted a diminished quality of life, men who assumed nothing could be done without medication, men who had been told by well-meaning but inadequately informed physicians that this was simply a feature of getting older. It is not. What I am going to describe today is free. It is based on clinical research, and it works when done correctly and consistently. Let me start with the physiology, because understanding what is actually happening in your body makes every step of this approach make sense. An erection is, at its core, a vascular and muscular event. When sexual arousal occurs, the parasympathetic nervous system releases acetylcholine and vasoactive intestinal peptide, which stimulate the endothelial cells lining the penile arteries to produce nitric oxide. Nitric oxide diffuses into the smooth muscle of the arterial walls and causes them to relax. The arteries dilate. Blood rushes in under pressure into the two corpora cavernosa, the paired erectile chambers that run the length of the penis. As these chambers fill, they expand against the surrounding tunica albuginea, a tough fibrous envelope, and simultaneously compress the subtunical venules, restricting venous outflow. This venous restriction traps blood inside the erectile tissue under pressure, producing firmness. A full erection requires all three components: adequate arterial inflow, adequate venous restriction, and adequate smooth muscle function within the erectile tissue itself. When erections become weak in men over 60, one or more of these three components is impaired. The most common impairment in the arterial inflow mechanism is reduced nitric oxide bioavailability, caused by endothelial damage from years of hypertension, diabetes, or atherosclerosis, and compounded by the age-related decline in endothelial nitric oxide synthase activity. The most common impairment in the venous restriction mechanism is veno-occlusive dysfunction, caused by structural changes in the erectile tissue, specifically the progressive replacement of flexible smooth muscle with collagen that occurs when erectile tissue is chronically underoxygenated. The Ischiocavernosus muscle runs from the ischial tuberosity, a bony prominence of the pelvis, to the base of the corpus cavernosum. When it contracts during erection, it creates additional compressive pressure within the corpus cavernosum that can raise intracavernosal pressure to levels significantly above mean arterial blood pressure. This superpressurization is what produces the rigid erection phase, the phase of maximum firmness that is distinct from the tumescent phase of lesser rigidity. Without adequate ischiocavernosus function, erections may be tumescent, full of blood, but not rigid. The man has an erection that is present, but not firm enough for penetration or for sustained, satisfying sexual activity. This is exactly the complaint I hear most often from men over 60. The ischiocavernosus and bulbocavernosus muscles undergo the same age-related atrophy as all skeletal muscles. Sarcopenia affects the pelvic floor just as it affects the quadriceps and biceps. In sedentary men, this atrophy is accelerated. In men who have undergone prostate surgery, radiation, or pelvic procedures, these muscles may have been partially denervated or mechanically disrupted. The result in all these cases is the same: reduced compressive force during erection, reduced rigidity, and reduced satisfaction. A landmark randomized controlled trial published in the British Journal of Urology International studied 40 men with long-standing erectile dysfunction who were randomly assigned to either pelvic floor muscle training or a lifestyle advice control group. After 3 months, 40% of men in the pelvic floor training group recovered normal erectile function, defined as IIEF scores in the normal range. Another 35.5% showed significant improvement. In the control group receiving only lifestyle advice, the improvement rate was less than 10%. These results, a 40% full recovery rate from pelvic floor training alone, are comparable to the efficacy rates reported for low-dose PDE5 inhibitor therapy in mild to moderate erectile dysfunction. And unlike medication, the benefits of trained muscles are permanent as long as training is maintained. Let me now give you the specific exercise protocol that I walk every patient through. The critical first step is identifying the correct muscle group, and this is where most men go wrong when they attempt Kegel exercises. Most online descriptions of Kegel exercises for men focus on contracting the urethral sphincter, the muscle used to stop urine flow midstream. While this muscle is important for urinary control, It is not the primary target for erectile function improvement. The target for erection quality is the Ischiocavernosus, a slightly different contraction that is felt specifically at the base of the penis and perineum, not primarily around the urethra. The muscle needs to recover, and the neurological signal to relax is as important to train as the signal to contract. Perform 15 repetitions per session. Complete 3 sessions per day, morning after waking, midday, and evening before sleep. This gives you 45 contractions daily. After 4 weeks of 3-second holds, progress to 10-second holds with 10 seconds of complete rest between each. Reduce the number of repetitions to 12 per session, but maintain 3 sessions per day. After 8 weeks of 10-second holds, add a resistance component. At the peak of each contraction, perform 3 rapid additional pulses, short quick squeezes, before releasing. These rapid pulses recruit fast-twitch muscle fibers that contribute to the explosive pressure increase during the rigid phase. Now please subscribe to this channel right now. I am Dr. James Whitaker, and I produce this level of detailed clinical content every single week. Hit subscribe, hit like, drop a comment below telling me, have you ever been told about pelvic floor training for erectile function? Did your doctor mention this? I read every comment, and I want to know how many men have never heard of this intervention. The second component of the #1 trick involves morning erection optimization, specifically using the nocturnal erection period as passive erectile tissue rehabilitation. Nocturnal penile tumescence, the erections that occur during REM sleep, serve a documented biological purpose. They deliver oxygenated blood to the erectile tissue, preventing the fibrotic changes associated with chronic underoxygenation. Men who have fewer or weaker nocturnal erections have faster progression of veno-occlusive dysfunction. Maximizing nocturnal erection quality is therefore a direct intervention against the structural changes that cause weak erections. The most effective ways to optimize nocturnal erection quality are eliminating alcohol in the evening. Alcohol suppresses REM sleep and dramatically reduces nocturnal penile tumescence frequency and quality. Treating sleep apnea if present. Sleep apnea fragments REM sleep profoundly, often eliminating nocturnal erections almost entirely, and CPAP treatment frequently restores morning erections within weeks, and sleeping in a position that does not compress the perineal vascular supply. Most men find supine or lateral positions with a pillow between the knees most comfortable while maintaining good perineal blood flow. The third component is dietary support for nitric oxide production. The penile arterial endothelium produces nitric oxide through 2 pathways. The enzymatic pathway using endothelial nitric oxide synthase, which declines with age and vascular damage, and the dietary nitrate pathway, which converts dietary nitrates from vegetables to nitric oxide through a bacterial-dependent process in the oral cavity and stomach. This second pathway does not decline with age and can be significantly boosted through diet. Foods rich in dietary nitrates include arugula, spinach, beetroot, Swiss chard, and celery. Consuming a large serving of these greens daily, or drinking 200 milliliters of beetroot juice, provides a meaningful boost to nitric oxide availability that directly supports the arterial dilation mechanism of erection. These are not replacements for exercise and pelvic floor training. They are powerful adjuncts. Your complete 8-week protocol. Begin pelvic floor training today with 3 daily sessions of 15 3-second Ischiocavernosus contractions. Begin 30 to 40 minutes of brisk walking 5 days per week. Eliminate alcohol from evening hours. Add daily leafy greens or beetroot juice. Assess your morning erection frequency and quality monthly as your objective progress indicator. If after 8 weeks of strict adherence improvement is insufficient, schedule a urological evaluation, including testosterone panel, vascular assessment, and medication consultation. I am Dr. James Whitaker. This trick works. It is supported by clinical evidence. It is free, and it produces results that surprise men who have spent years accepting something they did not have to accept. Subscribe for weekly content. I will see you in the next video.